Okay, so now I'm intrigued, and I was delighted to get an invitation to this precious meeting of yours, and the German Ophthalmological Society and the All India Society are working together, and the first slide is a picture, as you know, of Albrecht von Graefe, and also of our logo. And it was in fact Albrecht von Graefe who initiated our society in 1857. So it is fairly old, and we're still going strong. And I'm absolutely honored and proud to be president for a year of that society. Now, before I start my talk, I would like to highlight one date also for you, because the program of our yearly conference in September, October will be held also in English. So every day you have a string of English talks you can attend if you want to. And just Google our homepage and you just get through to the program and to the conference if you want to. But I'm not here. I'm not sitting here talking about our next conference because it's yours, and I would like to share some data and some techniques with you in the glaucoma surgical field, which is canaloplasty. And this is the topic of my talk. Would like to share with you some experience with the microcatheter, Alex catheter, ab externo canaloplasty in adults and children. Now, as you know, the technique was developed by Stegman. So this is the overview. I just have three topics: long-term results in adults, and what I do with the catheter with my group in childhood glaucoma, severe childhood glaucoma. So as you know, Stegman in South Africa developed the technique because he was fed up doing traps and colored people and blacks. So he thought about a technique that gets away from the bleb towards the inner Schlemm canal collector channels to open them up. So it's quite similar to viscocanalostomy, and he developed that technique in 2005. And the name below Stegman is Professor Kerber, who introduced the same technique in 2005 in Cologne, actually, where for Professor Prokofievich is sitting right now. And as he was a close friend of Stegman, he let him have the technique straight away. So he started in 2005, and the data I'm going to present are his data. They're not my data. I just followed them up and worked them through. So he did the surgery. I'm not the one who did the surgery. So I must be clear about that. So we have data that are fairly old from canaloplasty from 2005 to 2007 that I'm going to present. It is an illuminated microcatheter that had lots of advantages, as you know, and the final goal of the surgery is to situate a Prolane 10 zeros Prolane suture in Schlemm's canal to dilate and keep the Schlemm canal open. Now, you also have Helon GV to dilate Schlemm canal and collector channel, but I personally think the primary goal is to place the suture and hold the tension. And I'm going to show you a brief video how to exactly do this. I hope it's running now. We just take a minute to watch this. The suture is already placed inside Schlemm's canal all the way around. You see it's very tiny. You have the lower flap, it's been cut away, and you have to suture that 4 times. You have to sling the suture around each other 4 times so it doesn't flush open, be open again once the tension is released. Now what I'm doing now is I pre-lay the suture on the Descemet's windows. And this is the essential trick. What you're going to see now is that you have to put down the pressure of the eye to 0. So you have an hypotony. Once the hypotony is achieved, then you can place the suture tension. Many people don't do that, and then this canaloplasty just fails. Here you can see the tension. Okay, you can actually see how Descemet's window is pulled in. And the result of this is that you have, once the pressure is going up again to normal rates or to the pressure you want to achieve, that the tension is increased in the suture, and it dilates Schlemm's canal to the maximum. And this is what you need. You can see that actually in the next slide, where you can see the pre-surgery OCT compared to the post-surgery OCT on top. You can actually see a slit open and the Schlemm canal is dilated. This is done by the suture. It's not done by the Prolene or the Helon injection. All right. The Helon injection just gets to the collector channels and disappears fairly quickly. But this suture is held for many, many, many years. You can see it in gonioscopic view, as seen here in the chamber angle. And you can actually do something with it once canaloplastic fail, which it doesn't very often. So this is very briefly the retrospective study design. It hasn't been published yet because it's been part of an habilitation, which in Germany is prohibited to be published. But we are going to do that in the future, in the next, in the future soon to come. So these are the canaloplasties I mentioned, the years, and we have the exclusion criteria or previous surgery, apart from normal phaco and normal EVOM. The intravitreal injections, and the successes here defined as below 18, as you know, and definition 1 to definition 2 without and with drops as complete or partial success respectively. And this is the overall rule. There were about 70, more than almost 80 patients involved. And you can see over the years, over 10 years follow-up, that the procedure is actually working very nicely long-term, very nice. You can see the patients' numbers drop because some of them are lost follow-up, of course, over the long time period. Some of them died. So these are the basic data, and you can see the pressures is fairly low with a few drops, which is not the total success, of course. These are the Kaplan-Meier evaluations of the 4 different survival functions and cumulative survival rates, and you can see 125 months is quite a long time for a study. And you can see that the technique works fairly good. These are the pressures over the years, 11 in total, and it's bringing the pressure down fairly nicely. We had very few complications. Not we, Professor Kerber had few complications, high Thieme, corneal edema, iris adhesions, very little complications. Now, this is a video of something that that Dr. Pandav already showed. This is pulling the suture after failure of canaloplasty when the pressure goes up again. You can do, by pulling this, a 360-degree trabeculotomy, which works very nicely as an exit strategy. I can conclude, before I talk about the children, I can conclude from these long-term data that canaloplasty is safe and effective, that the partial success rates over the years is very high, and the complete success as well. And it, as you've seen, it requires skillful microsurgery, but it's rewarded by good results. Now, for the children and congenital glaucoma cases, these are just briefly the time frame I just looked at. It's 5 years in the past, and in Germany, it's not a very frequent operation or illness that we are presented with very often, because it's very rare. As you know, this is what we found: Axenfeld, Rieger, Sturz-Weber. And there's quite a difference between the ages and the ages of the patients. And 12 of these received 360-degree trabeculotomy. What is that? Now, this is actually a technique that uses the catheter all the way around. I always use very much like the external approach, because I don't want to create cataract, especially not in children, especially not in those children. And the yellow color you're going to explain later. But once the suture is going, once the catheter is going all the way around, you actually just pull both ends and use the catheter as a cheese wire to open up the meshwork. Here you go. And you just pull out and close the wound without a bleb, and you can already see the anterior chamber bleeding present. These are the data. So the children worked out very nicely. None of them had hypotony of thesis bulbi, all worked fine. And when you make one of these children happy, you make at least 2 parents happy as well. And I mustn't tell you that. Now, this is canalography, which I always perform when I have a little child receiving this procedure. Look at this area here. You can see the bleaching first, and then once the fluorescein is injected into Schlemm's canal, you can actually see how it works out and fills collector channels and later the upper and lower conjunctiva and tenon vessels. This gives me a good hint whether whether a 360-degree trabeculotomy will work in children, because once this is present in a child, usually the pressure goes down very nicely. If it is not present, usually the children go for Ahmed or Beveled implantation. So it gives us a clue how the exit of aqueous humor out of these children's eyes is actually done and anatomically present or not. So I always perform canalography in childhood glaucoma. So in conclusion, I'm at the end of my talk in 10 minutes. Canaloplasty is not a fast procedure, but has very good long-term results in adults, is bleb-free, which I like. Professor Pfeiffer will talk about the blebs, and I love blebs as well when I need them. But it is bleb-free. Leaves the aqueous where it should be and should drain, and opens vast diagnostic options for childhood glaucoma cases. Thank you very much for your attention.